I am Dr.K Gireesh, physician, neurophysician and neurosurgeon. Under the banner of Health Bouquet, there is a health awareness program for the public on various medical topics. Now, the present topic is a sequel or a series, comes under a series of topics which I have already spoken on various facets of sleep and sleep disorders. Today, I will be speaking to you on excessive daytime sleepiness or the hypersomnia. That is called narcolepsy. It's a chronic disorder, one type of hypersomnia. Narcolepsy is a chronic disorder of hypersomnia in which there are sudden onset of sleep episodes or a sleep attack, which can be associated with cataplexy, sleep paralysis and hypnagogic hallucinations, and it disrupted nighttime sleep. So, suddenly the patient will, as he is sitting and talking to you, suddenly he goes in for a sleepy mode and he sleeps off. But there are other three associated features that can occur: cataplexy, sleep paralysis and hypnagogic hallucinations. These three I will explain. The narcolepsy can be type 1 and type 2. Between type 1 and type 2, the differences in type 2, cataplexy is not there. There is a sudden onset of weakness. That is not there. Type 2. Type 1 and type 2. So, let us see what is the type 1 and type 2. In addition, the hypersomnia is not better explained by another sleep disorder, medical or neurologic disorder, or a psychiatric disorder, medication use or substance use. So, that is how you diagnose narcolepsy. There is a word terminology of narcolepsy is used only when it is in a type 1 or a type 2 and should be confirmed by a polysomnography followed by a Needle's sleep latency test. In addition, this hypersomnia is not explained by any other sleep disorder like medical or neurologic disorder or a psychiatric disorder or a medication use or substance abuse. There are two types of narcolepsies, type 1, type 2. Type 1 is characterized by irrepressible need to sleep. He has uncontrolled, he has to sleep, or a daytime lapses into sleep occurring, or for at least 3 months he will be having this. That is one criteria. In addition, there may be one or more of the following criteria. 1, cataplexy with a mean sleep latency of equal to 8 minutes, or 2 or more sleep onset REM periods, which is called REM on MLST. A CSF hypocretin 1 concentration which is less than 110 picogram per ml. So, these are the two other criteria for diagnosing narcolepsy type 1. Narcolepsy type 2 is similar to type 1 except there is no cataplexy and CSF hypocretin is almost normal or more. This is the two differences between the both types of narcolepsy, type 1 and type 2. So, type 1, you have hypersomnia, you have urge to sleep, and you have cataplexy, you have associated hypnagogic hallucination and sleep paralysis. Whereas in type 2, and you find hypocretin is more, hypocretin is deficient, whereas in type 2, you find hypocretin is normal and there is no cataplexy. Now, what is cataplexy? Cataplexy is a condition characterized by sudden onset or sudden episodes of muscle weakness or paralysis, but no loss of consciousness. If sudden onset of muscle weakness or loss of tone with loss of consciousness means it can be atonic epilepsy. So, this is cataplexy, does not have loss of consciousness, but this is precipitated by a laughter and excitement. See, these are things that can actually precipitate this, and this can last from a few seconds to several minutes, and sometimes they may go into a sleep. And the other, the cataplexy, sleep paralysis and hypnagogic hallucination can occur. Now, what is sleep paralysis? Sleep paralysis is characterized by a recurrent inability to move the trunk and extremities either at sleep onset or upon awakening from sleep. They cannot move at all. So, eye movements and respiratory efforts are not impaired. Each episode lasts from seconds to a few minutes and typically resolves spontaneously. The episode causes clinical significant distress with the bedtime anxiety or fear of sleep actually because of the sleep paralysis. He suddenly feels that he is not able to move any part of his body. Sleep paralysis seen in patients with narcolepsy, but is not necessary for the diagnosis of either type of narcolepsy. Sleep paralysis can occur sometimes in normal individuals too. These are some of the features of this is the sleep paralysis. The next one is hypnagogic hallucination. We said cataplexy, sleep paralysis and hypnagogic hallucinations. Hallucinations, you are hearing something which it is not there. It can be visual, auditory or anything. So, hypnagogic hallucinations occur during the sleep-wake transitions, either when falling asleep or what you can say when waking up, and can involve various sensory modalities, but most commonly it will be visual. That is, you see something which is not there. Okay? That is hallucination. Although this entity is typically observed in association with narcolepsy, it occasionally occurs in normal individuals. What is the cause for this? It is firmly established that narcolepsy type 1 is caused by a deficiency in a neurotransmitter called hypocretin or orexin, which is actually originating from the hypocretin producing neurons in the hypothalamus. The majority of patients, almost 90 to 95% with narcolepsy type 1 have undetectable or low levels of hypocretin in the CSF. The HLA association in narcolepsy, that is HLA DQB10602, that has actually led to the hypothesis that it could be an autoimmune mechanism that could potentially explain the selective destruction of the hypocretin containing neurons in the hypothalamus. However, this is not diagnostic of narcolepsy. So, that is exactly important. So, this is the etiology, that is narcolepsy type 1. There is a deficiency of hypocretin which is being secreted by the hypocretin secrete producing neurons in the hypothalamus. Now, how do you treat this? And it has got non-pharmacological options can be tried. You can actually have a nighttime sleep and scheduled daytime. You can actually have schedule and ask him to go ahead with that. A scheduled 15 to 20 naps in conjunction with a medical therapy can be tried. Modafinil is an effective pharmacological treatment of daytime sleepiness in adults. Other stimulant medications can be given like methylphenidate, dextroamphetamine. They are also effective. Then sodium oxybate is another drug which is effective for the treatment of daytime sleepiness, cataplexy and disrupted sleep due to narcolepsy. Alternatively, cataplexy as well as sleep paralysis are often treated successfully with tricyclic antidepressants like imipramine or selective serotonin reuptake inhibitors like venlafaxine. So, these are some of the methods in fact to treat narcolepsy. So, that is in brief on narcolepsy, the features, the type 1 and 2 as well as how you differentiate them as well as the management of it I have already told you. Thank you very much.